Hello and welcome. Many people, including infected patients who lose their lives to COVID-19, do so because they suffer from some pre-existing conditions or comorbidities, as we call them. And a key comorbidity in itself is diabetes. What if we had a better understanding of who the diabetes patients were, their current health condition, and we were able to maintain some kind of continuous communication channel with these patients wherever they are, particularly if it's in a country or a city, or a small province for that matter. Well, my guest, Dr. Deborah Wake, co-founder of My Way Digital Health, has done precisely this in Scotland as part of an academic project turned venture, and which looks at firstly putting together all the data and then using high quality machine learning and artificial intelligence to understand what are the trends, and then obviously to respond to that in a manner that's more of a public health response. Well, I'm now joined by Dr. Deborah Wake from Edinburgh. She is, apart from being the co-founder, also a clinical reader in medical informatics at the University of Edinburgh. Dr. Wake, thank you very much for joining us.
No problem. Lovely. Thanks for having me.
Right. So tell us, tell us about this database that you built of diabetes, patients in Scotland, and how does that link to the challenge of COVID-19 that we are facing today?
Yeah. So over the last 15 years or so in Scotland, we've taken a national approach to managing diabetes. And we've linked up all the data from all the healthcare systems, including the primary care, general practice systems, the hospital systems. And we've also started bringing in data that people with diabetes themselves produce, things like data from glucose meters. They might be measuring sugar levels at home, activity monitors, weights and blood pressures, and other things that they can now do in their own houses. And we use that data to really help understand our population better. And it allows us to respond in a very personal way to them and their needs. So we use it in the clinical setting with clinicians like myself, using it every day in clinics to help us understand the problems patients are having. The computer simulation of the data can also help us really personalise our approaches to these patients. So it can pick up who are the high risk patients, for example, who are the ones who are overdue certain testing, who are the ones who are likely to have reactions to certain drugs, and who are the ones who are going to respond in a specific way to certain treatments. And that way we can really plan and support them personally. We also use our computer systems to communicate directly with patients, not just with the clinicians, but helping them understand their condition better by giving them access to their data and explaining it in a really understandable way so that they know what their targets are for all the key parameters, and also giving them personal links to things like self-management advice, education courses, and direct feedback on the results, which will hopefully improve their healthcare.
Right. And what's your sense or understanding of the mortality figures that you've seen, or for that matter, patients who, where the disease has progressed from mild to moderate to severe, and the link with diabetes, at least in the last few months?
Yep. So we know that with diabetes, it's a progressive condition, particularly type 2 diabetes. So the longer you have it, the more likely you are to develop complications like heart attacks, strokes, amputations, kidney failure, blindness, and so on. And these complications are very costly. About 80% of the cost of diabetes is spent treating these complications. And for most healthcare services, it consumes between 10 and sometimes even up to 20% of their entire health budget is spent treating diabetes complications. I say most of which are preventable, most of which we know the cause of. And if we implement the right treatments at the right time and get patients to better manage their lifestyle, most of these could be prevented. In terms of COVID, more recently, what we found is that people with diabetes are at much higher risk of having poor outcomes with COVID, either being severely infected or dying from COVID. And in fact, in the UK, about 25 to 30% of COVID deaths were in people with diabetes. In other environments, that's as much as 40% of people who died from COVID had diabetes. And we know the main risk factors are age. So if you're older, then your outcomes are poorer. But also it's linked to things like obesity. So the more overweight you are, also the higher your blood sugar levels. And in general, the control of your diabetes is a very good indicator for how you're likely to respond and what your outcome's likely to be to conditions like COVID. So the more we can do to help people keep their weight managed well, keep their sugar levels managed well, and reduce their other risk factors like blood pressure, cholesterol, and self-manage their condition better, then we can really have a huge impact on their outcomes for conditions like COVID, and more generally, the risk of developing other diabetes complications.
Right, and you did mention that 80% of costs of managing diabetes come from other conditions. Now, I'll come to that in a moment. But the database itself, how did it come together? What is the kind of effort that went into it, and how do you keep this database running actively? For instance, right now, do you know for a fact or for sure that there are so many patients who are across the country or region who are either doing this or not doing something as they're supposed to?
Yeah, we do. So it's pretty unique internationally, the database. We have registered on it. 99.9% of people with diabetes in the country are registered on it. And pretty much the day they're diagnosed with diabetes, the systems will pick it up and they will push the information onto our registries. We collect information at least on a daily basis from all the key systems. So it's completely up to date in terms of the data, to the extent that if I see a patient in the hospital clinic and they've been to their general practice the day before and had some tests done, all that information is available to me. And a lot of the data will come in almost real time. So it is a real live functioning system that is continually updating. And through the additional artificial intelligence, machine learning analytics that we put into the system, it means it can constantly be flagging, again, in a real time way, patients that are high risk, patients that should get started on certain treatments, patients that need additional support. That's really important at the moment with COVID, because we're trying to reduce the number of patients we see face-to-face in the clinic, because we know there are significant risks with clinical contact. So it helps us stratify which patients we really need to be seeing face-to-face, which we can safely defer treatment, and it helps us rationalise the limited resource we've got and keep people safe during COVID. We're also using a lot of the remote communication functionality with patients, so that if we're not bringing them in, we can communicate with them through the platform, get them to upload data and keep that conversation going. And we've now been able to take that system in Scotland and develop it into other areas. So similar systems are now running across large regions in England, and we're starting to pilot those in international territories as well.
Yeah, and including in India, and if I understand correctly, how many patients do you have right now as part of this database?
So in Scotland, we've got about just over 300,000 people with diabetes in Scotland, and they're all contained within our Sky Diabetes database. And a certain percentage of them will have chosen to also use our sort of data-driven system in terms of accessing their health record and use more of the deep functionality. But we've got data in Scotland going back about 20 years on about 500,000 people with diabetes. And that's obviously been a great resource for data mining and artificial intelligence and starting to really understand the trends within the data for people with diabetes. So that's a pretty unique resource for us to do that. Whenever we go into new environments, obviously it takes a bit of time for us to make those connections into the IT systems to create that kind of level of data integration. But that's part of what we do when we go to a region. We understand that the data is so important that the first task we do is understand what are the key IT systems in the area, put in new systems for the clinicians to start collecting their data in a more transparent way, and set up a system that the patients understand the functionality and can start to upload their data. And as you said, we're now doing that in other regions like England, the US, the Middle East, and we're starting some pilot work in the north of India as well.
Right, and you talked about that cost of management and the 80%, which is basically other forms of, for instance, on cardiology, cardiological or strokes. Now, tell us, how have you seen this linkage between the two evolve? In as much as are people able to understand the what really happens when they have diabetes and how things can go wrong?
Yeah, no, that's a great point. So one of the key things we're trying to do is use the data to really help inform patients and give them a much better understanding of diabetes, because you're absolutely right. When people are diagnosed, they may have limited symptoms, and these complications occur a few years down the line, and often people won't take notice of that, or just may not have a good awareness of actually the risks that they're putting their body under by not maintaining good control of their diabetes. So what we try to do within our system is make it really clear to patients what their targets should be for things like blood sugar, blood pressure, cholesterol. If they're not achieving those targets, we push them more information to help them understand why they need to be achieving those and what the long-term risks are if they don't. The other thing that we're doing in a more granular way is now developing like a risk prediction engine for patients. And what this does is it allows them to look at their current parameters, and it will predict on a very personalised basis their risk of all these different complications. We don't want to scare people, but we want to be realistic about, what risks they're at. But more importantly, what we then do is we give them a separate engine that allows them to change those risks so that they can see what happens if I give up smoking, what happens if I lose 10 kilograms in weight, what happens if I start taking my cholesterol tablets again, and so on. And they can really begin to understand that the impact they can make by the lifestyle changes to their downstream risk. And that can be really quite sort of eye-opening for patients to be able to kind of actually see that, visualize it, understand what they can do to modulate that risk, and it can be a real motivator. And we feed that into the kind of goal setting and behaviour change that we then work with patients to try to achieve those goals.
Right. And as you look ahead, do you see this database becoming bigger or expanding in some ways, going beyond diabetes?
Yeah, no, absolutely. So we're already doing some work in the at-risk group. So these are people who don't yet have diabetes, but who are at risk of it. And they're almost as big a group as the people with diabetes. They need a slightly different approach, but actually a lot of the fundamental principles are the same. But we're also starting to look in other sort of disease verticals like cardiovascular disease, hypertension on its own, kidney disease, and so on. So many of these chronic conditions, actually, the same principles apply. It's just the messaging and the educational support that's slightly different. So we've already started working in these other disease verticals, and we're keen to kind of expand the work that we've done into these other areas. And people with diabetes often don't just come with one condition. Often they have other comorbidities. So it's really important for us to kind of take that whole person approach and try and make sure that we're giving them appropriate advice, even if they've got, let's say, lung disease or some other condition that is linked, but requires additional support.
Right. If it would be good to be part of a database which is talking to you and telling you about what could be lying ahead. But for those who do not have access to a database or who's watching this, what are your key points of advice in terms of what they should be or should not be doing, particularly if they are either on borderline diabetes or diabetes at a time of COVID-19?
Yeah, no. So absolutely. And one of the first things we do often when we go into new territories, when we can't set up a database straight away, is just put in some really good educational advice for people with diabetes. So make sure that there's good public access to good education, public health education. And we're actually going to be running some free online courses in India, for example, which we'll advertise. And that will be open to anyone with diabetes to come join us for a couple of days and learn more about what they can actually do to improve their outcomes. But a lot of it is quite sort of straightforward advice. It's about a lot of people with diabetes are carrying too much weight. So it's important to get your weight down to the what would be seen as the normal body mass index. So maintaining that kind of weight at a good weight is really important. Activity and diet are key. So trying to stick within sort of government guidelines for activity, making sure you're staying active. Maintaining a good diet, trying to avoid high carbohydrate foods, sugary foods or starchy foods as much as you can. Keep your calorie intake down. All the sensible sort of stuff. But also it's about turning up for your diabetes appointments, taking your diabetes medication, looking after your feet, because actually a lot can go wrong with your feet if you've got diabetes, and that can lead to significant problems. So checking your feet every day, washing them, looking after them, making sure that they're well cared for. And as I say, taking your medication appropriately so that we know things like blood pressure, cholesterol are well controlled. A lot of people with type 2 diabetes now can actually reverse their condition. So there's a lot of evidence now emerging around diabetes remission. So this is when people can actually push their diabetes back into remission at a point that their sugar levels are essentially normal and they don't need any medication to control their diabetes. So there's a really strong message for people if you've been fairly newly diagnosed with diabetes in the last few years. Actually, if you really take this lifestyle advice seriously, lose the weight you need to lose, then actually there is a chance you can remiss your diabetes. And that puts you in a much, much lower risk group for any complications that might otherwise happen.
Right, that's a very positive note to end on. Dr. Deborah Wake, thank you very much for joining us and sharing your thoughts. And I do also wish you and your team all the very best as we continue our fight against coronavirus.
Thank you. No, thanks for having me. It's a delight.
Thank you.